Dear colleagues and friends, good morning, good afternoon, good evening. Today we have another important webinar that GHD ImpNet has used to do over the last 1 year almost. And today really we are going to tackle one of the very important topic in primary healthcare issues, which is the public-private partnerships, with a special emphasis today on immunization. In fact, the Asatana Declaration on Primary Healthcare reiterated that primary healthcare is a cornerstone of the sustainable health system for universal health coverage and health-related sustainable developmental goals, SDGs. It called for governments to give high priority to primary healthcare in partnerships with their public and private sector organizations and other stakeholders. In fact, to improve the healthcare delivery system and to overcome the limitations of financials, technical, and human resource aspect, public-private sector partnerships should be considered for health reforms. In fact, each country has a unique path towards universal health coverage, and different models for public-private partnerships are quite possible. Public-private partnerships can lead to improvement in the efficiency and effectiveness in service provision. However, there are some concerns that some public-private partnerships are weak, as developing countries don't have usually the resources to monitor the quality of provided health services. In fact, the goal of this webinar is to discuss evidence on the use of the public-private sector partnerships in the provision of primary healthcare services, including immunization. Also report the challenges and potential recommendations that can come from this discussion. The webinar will focus on the following. Number one, highlighting the impact of public-private partnerships on the primary healthcare, with a focus, as mentioned, on immunization and polio eradication. Secondly, identifying the main challenges of public-private partnerships at the global and EMRO countries. And thirdly, discussing appropriate strategies and modalities to minimize these public-private partnerships challenges to reach the immunization goals. In fact, we have today distinguished colleagues that are going to cover these areas, starting first of all with Dr. Gina Hill, who is the Associate Director for Policy Partnerships within the Global Health Global Immunization Division at USCDC. And we have also supposed to have also Dr. Randa Ahmadi, who is the Director of Primary Health Care in the Ministry of Public Health, Lebanon, but we are going to have Dr. Rima Shaya on her, who is going to present on her behalf. Also, we have, suppose we have Dr. Ghulam Nazari, who is the National API Manager in Afghanistan, but due to certain logistic issues, unfortunately, he will not be able to attend. And we are going to have Dr. Perwiz, who is going to present on his behalf. Allow me first to ask Dr. Gina Hill to present the first presentation, and just a quick Gina Hill, as I mentioned, she is the Associate Director of Policy and Partnerships within the Global Immunization Division at the USCDC. She has worked with domestically and internationally in immunizations and HIV/AIDS, and now leads a global immunization effort to expand immunization across worldwide. She was recently deployed to the CDC's COVID-19 response as the Policy Partnerships and Communication Lead for International Task Force. And since she joined the CDC in 1999, she has worked in public health for more than 2 decades and at the CDC, leading policy, public-private partnerships, and communication activity for viral and bacterial respiratory infection. Dr. Gina, you have 20 minutes to present your slides, and we will keep the questions and answers at the last, after the three presentation. Dear colleagues and friends, if you have any comment or a question, you can use the Q&A for your questions, and we are going to review them periodically, and we are going to address them at the end of the three presentations. And also the colleagues, the presenters, sometimes can give a direct answers through the Q&A button. Dr. Gina, if the floor is yours, please, you can start.
Thank you. Thank you so much for that warm introduction, and good morning and good afternoon to everyone. I just want to thank the organizers today for inviting me to speak today on public-private partnerships. And so today, I just wanted to share with you some of our perspectives on, how does public-private, how do we engage, why we engage in public-private partnerships, describes the CDC's partnership model, and provide an in-depth deep dive into the Global Polio Eradication Initiative and the Measles and Rubella Initiative, where CDC is a spearheading partner. And then finally, sort of end with some of those evolving challenges and issues in private-public partnerships. It's a mouthful this morning, sorry. So, just to start off, I always like to reference Dr. William Fagey, Bill Fagey, who was a former CDC director, but he's also a champion for global health. And, one of his things that just reminds me of, I read his book about the Task Force for Child Survival and the work he has done in sort of for the eradication of smallpox. With that being said, it just reminds us why partnerships are important. Partnerships are, as you know, is not a sort of a new concept, but the role the partnerships play in global health, and especially in immunization, helps us address the most pressing problems. Partnerships can take on many forms, and we've seen it work during, as I mentioned with Bill Fagey, with the eradication of smallpox, steps taken to contain Ebola outbreaks in West Africa, and recently we're navigating new partnerships in relationship with the global COVID pandemic. As we see, partnerships are an important tool that helps sort of extend and reach the messages, the programs to secure political commitment or will or support. And they also offer flexibility and effectiveness. And they solve problems through technologies and innovations, and they develop and strengthen the work for those addressing public health issues. And so for that, I think that's really important. And just these are a few things of why funding partnerships important. It allows us to consolidate our resources when resources are constrained, and also gives us the workforce, the staffing or the volunteers needed to help us finish the job, whether it's on eradication or elimination efforts. So there are many elements that make a public-private partnership successful. Highlighted on the slides are key elements or secret ingredients that make P3 successful. These are things that I personally feel are really important for strength of a partnership. We view it as a win for all who are engaged, that everyone has a common sort of vision and mission objective of the strategy or the goal that we're trying to achieve. We also agree on common goals and strategies. And then to me, it's the most important is the recognition of respective strength and engagements of our diverse talents, realizing that everyone comes to the table with different skill sets, and it's really important to recognize that. And then also having that flexibility and being able to innovate with research and science is really critical for helping us achieve our goals. And then the critical piece is shared credit for achievements, which is critical. It's not just one partner at the table, but it's everyone takes credit for the achievements. And then the trust and the respect is a critical piece for success of the relationship and the communication between the partnerships. If you don't have clear communications, it could also jeopardize the strength of the partnership or how well the partnership performs. So I want to talk a little bit about CDC, just to give you a sort of quick a glimpse of CDC. CDC's global immunization program at CDC is guided by a vision of a world with healthy people protected from vaccine preventable diseases, disabilities, and deaths. CDC is dedicated to ensure that everyone everywhere share in the benefits of immunizations. And CDC's partnership models takes on, as you can see, takes on many forms to conduct our immunization work. We have bilateral relationships with countries that could be sort of one-on-one government to government relationships with the countries. We work with multilaterals like WHO, UNICEF, IFRC, and Gavi. We work with foundations like the Bill and Melinda Gates Foundation, UN Foundation, Rockefeller Foundation, Johnson & Johnson, just to name a few. And then we also work with the academia to explore new research and innovations. And the critical piece is a lot of the NGOs, civil society or faith-based organizations to help us complete our work. And of course, you know, the public-private partnerships is a critical piece for our work. Our work is guided with partners. Our work with partners is guided by our globalization strategic framework. We recently released it this year. And right now we're currently developing an implementation plan about how we should work with partners and other implementing partners to reaching our goals for immunization. So next, I would like to talk about a public-private partnership that CDC is one of the spearheading partners. This is the Global Polio Eradication Initiative. The goal of the Global Polio Eradication Initiative is to complete the eradication and the containment of all wild and vaccine-derived poliovirus, so that no child can ever suffer from paralysis. The GPI was launched in 1988 after the World Health Assembly passed a resolution to eradicate polio. And then GPI, along with its partners, as you can see on the slide, have helped countries to make huge progress in protecting the global population from debilitating diseases, or particularly polio. I do want to mention that GPI does align with the SDGs, and these are some of the goals that align very well with GPI. But I do want to sort of recognize some of the partners who had the forefront is Rotary International. They're the ones who saw the importance of bringing this partnership together to help end polio eradication. So as I mentioned, you know, in 1988, polio was endemic in 125 countries, paralyzing over 300,000 children each year. Since then, thanks to the cooperation of more than 200 countries and 20 million volunteers, more than 2.5 billion children have been immunized against polio. Polio cases have fallen worldwide by more than 99%, and the virus is now found in fewest places ever. We are closer than ever to eradicating polio than we have been at any point in history. So right now we're down to 2 countries. So the next slide, I would like to sort of talk about just highlight some of the achievements of polio. Just for your awareness, you know, we have certified 5 of the 6 WHO regions are polio-free. India has been polio-free since 2011. Type 2 polio was eradicated in 2015. Type 3 polio was eradicated in 2019. And the Africa region recently certified polio-free, and it's been over a year. And then we continue to sort of watch out for outbreaks, but the outbreaks in the Middle East has stopped despite the conflicts. I think the key piece to the success of polio eradication is its partners. And as you can see, there are many partners and stakeholders that should be recognized, but the success of GPI is having clear roles and responsibilities from each actor. And as you can see, there is a diverse number of partners. You know, the key to GPI is led by national governments. WHO plays a global strategic role in sort of management. UNICEF is the lead for sort of social mobilization and advocacy, and also resource mobilization, where US CDC provides their scientific technical expertise and M&E, and Rotary is involved in resource mobilization and advocacy, and BMJF and the Gavi are sort of the latecomers to they joined the GPI recently, where it was a game changer when they came in, where they provided a lot of technical and financial resources and advocacy. BMGF brought in a lot of high net worth individuals and donors to support the effort. And Gavi, with its focus on routine immunization, has been a critical piece to rolling out the inactive poliovirus. And it's a critical piece as we move towards integration. Over. So for that, I would like to sort of share with you some of the best practices of polio, which is, it's a model for a lot of public-private partnerships out there today. Polio does have a shared vision. The shared vision, common vision is shared and is iterated with all the GPI partners. We share it, we speak with one voice. We have a clearly defined goal. So the eradication of polio, so no polio anywhere in the world. And we stick to that. And so that's our sort of a mantra, is that we do have to eradicate polio from the world. There's a set of tools and technical expertise that have been developed for polio, and we use those critical tools have been translated or transferred to other partnerships to help them with other global immunization initiatives. There's a diverse set of partners that I've illustrated, and innovations in research and program has been really critical. We've used GPS technology, the microplanning for mapping out communities, and now with the novel oral poliovirus 2 vaccine has been a game changer for polio eradication. Another piece is the joint budgeting and financial accountability. This is a critical piece. We speak with one voice, and we have a financial resource requirement record, which shows what the budget for polio is. It costs about $1 billion a year to run the program, and so it sort of reflects all the critical activities needed to finish the job. There's strong governance ownership and driven by strong political advocacy, and then the one thing that I think we are sort of a game changer, we recognize the role of women as in eradication, the role they play in immunizing the children. And then I think the critical piece that I think it's real reflective of other initiative is that we continuously review our governance structures and operations to figure out the best structure to finish the job. And then I think for us, I think that's really a critical piece. And before I end, I do want to showcase, as part of that governance and restructuring, we have developed a new strategic plan and strategy, which guides us to finishing the job by 2022. And then also we do have a gender equity strategy, which also helps us to focus the importance of women and children for eradication. With that, I would like to now switch over to sort of Measles and Rubella initiative, which is another sort of public-private partnership that CDC is a spearheading partner for. The MNRI initiative is a global partnership, is led and coordinated to achieve a world without without measles and rubella. The Measles and Rubella Initiative, or MNRI, is led by the American Red Cross, the UN Foundation, CDC, UNICEF, and WHO. I think the critical piece is they do share the same elements as GPI of identifying clear roles and responsibilities, where WHO continues to play that global strategic planning role, whether it's at the global or regional level. And then you have UNICEF also at the global, regional, country level, providing that social mobilization and vaccine-related support. But then there's two new partners on the table that we haven't seen before, is the American Red Cross, who has provided advocacy work and strong volunteer support to work with countries and help vaccinate children. And then UN Foundation is responsible for resource mobilization and advocacy needs for the partnership. So since 2001, MNRI has vaccinated more than 2 billion children against measles. It also has reduced global measles deaths by 62%, and prevented more than 23 million measles-related deaths. These efforts have contributed significantly to reducing child mortality. You know, this is just to highlight some of the achievements. I mean, I think the world, due to COVID, there has been a pause in some of the vaccination campaigns, but I know countries are starting to restart these vaccination campaigns. But I just want to make sure that we do recognize some of the efforts that we have achieved. You know, we have measles elimination sort of goals in every region of the world. I think this is a little bit different from GPI, where they have a big one master global goal, but with the MNRI, there are measles related targets and goals that regions and countries adhere to. The region of the Americas has eliminated measles and rubella in 2002, and I think we're continue to make progress. I think as the world continues to open up, it would be good and to see what type of milestones or achievements we can achieve during that time period. So some of the best practices, I mean, it's similar to GPI. You know, we do have a shared common vision, clearly defined goals, and a set of tools and technical expertise, and then also a diverse of partners to help us do our work. And I think the one critical piece is that, similar to GPI, MNRI has begun to taken an opportunity to review their governance structure and their operations. One thing that's new to MNRI is the involvement of Gavi. Gavi does provide financial support for outbreak support for countries, and this has been a game changer in helping us sort of reaching those outbreak countries. But I think we, as the world continues to open up, we will see what opportunities MNRI will showcase for us. But I do want to highlight one sort of research or innovation that could potentially be a game changer for the world for immunization is the micropatch needle. This protocol it's a bandage which with microneedles attached to it with the measles vaccine, which is on the tips of the needles. Once the bandage is placed on the skin, the needles will dissolve, which will dissolve the vaccine into your skin. So for me, this is be a game changer, not just for measles, for any type of vaccine preventable diseases, because then we don't have to worry about how many shots we are administering to our child versus, where we can just place different colored bandages on a child's arm to make sure they're vaccinated. So I think for this, let's look out for the future, see where this new sort of innovation can take us. I do want to mention that, as you know, this is the new sort of immunization agenda 2030 is sort of a game changer of how we will work in the future for just any types of VPDs. And I think this structure is being currently stood up, but I think we should pay close attention to us because it is a bottom-up approach about how we should be working together to deal with vaccine preventable diseases. As a further note, I would like to highlight that measles and rubella, the MNRI initiative, is also a key component of the IA 2030. So it's listed as you know, from a global health security lens, measles is a tracer, which it signifies the weakness of the health system. And so with this in mind, it'll be good to see what the future brings with the collaboration with IA 2030 and measles and rubella. With that, I would like to sort of talk about sort of jointly some of the challenges or the issues evolving in public-private partnerships, whether it's from GPI, Global Polio Eradication Initiative, or MNRI, or any type of public-private partnerships. I think the most evolving challenge that we are dealing with today, and we're still trying to figure out how to address this, is COVID-19. COVID has turned the world upside down, and we are all trying to come back, begin to open up safely, but it's a new way that we do need to figure out how we will operate and how we will move forward with our initiatives. And I know it's a challenge with, when we're trying to vaccinate children, but then we do have that critical piece about what's the prioritization for immunization in the country when we're trying to introduce a new vaccine, but also resume routine immunization. I think the other piece it's a critical issue is the coordination of funding for health systems and infrastructure. As we're finding out, particularly with polio or even for measles, there are some donor fatigue in funding these areas. And this funding landscape is changing critically. It's changing rapidly. And so there's not a lot of domestic resources to go into sort of, vertical and going into initiatives. And so there needs to be ways to look at how do you coordinate funding that, whether it's for a health system or infrastructure, that also can also address disease specific areas. And then there's also these new funding mechanisms, like how will they work and how will they support other initiatives? For example, within the US, we do have funding for COVID. And one of the directives is what's the effects on COVID on other health programs. And I think how will this work? And when you're trying to sort of move towards our goals, and where does these funds begin and our routine fundings continue? And I think the other thing is governance and management of the partnerships. Those are critical issues. If you don't have strong governance and management, the partnership could fail. And I think it's really important that you have clear communication, clear roles and responsibilities to make a partnership work. And I think this is an evolving issue. It's something that we have to examine closely about what makes a partnership and the management of the partnership successful. And then I think the evolving issue was country ownership. When does a global or regional hand things over to a country, or how do we work hand in hand so the country can successfully own the issue? And I think that's a work in process, which I would love to hear more from our other speakers today. And then I think the other sort of evolving issue is the vertical versus horizontal programs. I think, for example, we've seen, we have a lot of horizontal immunization partnership programs or initiatives, but then you have these more systems-based programs that what takes away from a systems approach versus a disease approach, and which is the best. I don't think there's not a best, there's one over the other, but how do you complement a disease-specific approach versus a system-specific approach? And I think the thing that's really critical as we sort of close out this today, ending my presentation, is what are those evolving roles of multilaterals and how will they work in this environment? I think it's really critical to clearly define the roles of multilats. And then finally, what's the broadening role of research institutions and how that work impacts our day-to-day work? With that, I just want to say that was a mouthful, but I do appreciate the time, and I thank you, and I'm available for any questions. Thank you.
Thank you so much, Dr. Gina, for your great slides and the great presentation, and very insightful, really. And I'm sure a lot of the questions will be raised in the conversation that we are expecting to have on the Q&A. And really, it was amazing example. You have highlighted the issue of the polio eradication and measles and Rubella elimination. I think a very great example of how successful public-private partnerships can go on, and how this can be extrapolated and used for other vaccine-preventable diseases as well. And allow me now to introduce the second speaker. who's supposed to be Dr. Randa Ahmada from Lebanon, but on her behalf, we are going to have Dr. Rima Shaya. And Dr. Rima is currently the primary healthcare and EPI coordinator in the Ministry of Public Health, Primary Healthcare Department in Lebanon Ministry of Health. And Dr. Rima, she has a Master of Public Health with focus on health and health management and policy, sorry. And in fact, public-private partnerships in Lebanon is something unique because primary healthcare services are probably delivered to the public in Lebanon in somewhat a different way from other countries in the region, at least. So we are going to hear from Dr. Rima Shaya. So Dr. Rima, the floor is yours. You have 20 minutes for your presentation.
Well, thank you, Dr. Faris, for the introduction and for having me representing the Ministry of Public Health, the Primary Healthcare Department. As you said, I'll be presenting on behalf of Dr. Randa Ahmadi. First of all, let me tell you that the public-private partnership in Lebanon is a unique experience, and it's not a very easy mix. But it has provided the government with alternative ways of providing primary care services with regards to financing the service delivery and affording the infrastructure that is needed. So before I start talking about the current situation of the public-private partnership and the case of primary health care in Lebanon, focusing on the expanded program on immunization, let me give you just a brief history about the way that these partnerships started. As you all might know, in Lebanon in 1975, the civil war erupted, and it has lasted for more than 15 years, ending in 1991. And you know, Lebanon was part of the Al-Ma'ata Convention, and we have adopted the declaration and the commitment of the government to build a strong primary healthcare system. Unfortunately, after 1975, the government was very weak and was unable to implement this declaration. So at the time of the civil war, health services, ambulatory health services were delivered by NGOs in different regions, most of which were politically affiliated to different parties. So when the war ended and finally the government was strong enough to initiate a step towards organizing primary care as a step towards universal health coverage, in the early 90s, a network of 19 primary care centers was established. All of these centers were part of the NGO-owned centers that were providing the services throughout the Lebanese civil war. So this is just a background on how this public and private partnership came about to be in Lebanon. As I was saying, what started as more than a dozen of primary care centers currently is a network that comprises 246 primary care centers covering all Lebanese territory. The collaboration with the private sector is at all levels, at the level of governance, financing, and service delivery. At the level of governance, this network of primary care centers is built on the partnership with NGOs, academia, with other governmental organizations. And all these partnerships are bound by contractual agreement with the Ministry of Public Health that normalizes the roles and responsibilities of every party. So when the Ministry of Public Health is providing these centers with in-kind support, with technical support, the health information system, also the primary care accreditation, the managing entity, which is most of the time the NGO, covers the operational cost and commits to having the proper human resources and to implement the directives of the Ministry of Public Health and to keep the ceiling of their consultation at a limit that is set by the Ministry of Public Health. As I said, most primary care centers are owned by non-governmental organization, national non-governmental organization. It's 68% of the network is owned by NGOs. 21% is owned by municipalities. And sometimes it is a mix of a municipality and an NGO together. We have 9% are owned by the government. They are either centers that belong to the Ministry of Public Health or the Ministry of Social Affairs. And we have 1% of the primary care centers belonging to academic institutions and 1% to the military. At the level of service provision, all primary care centers provide 6 basic services. We have the family medicine, the dental services, the reproductive health services, endocrinology, cardiology, and pediatrics. So these are the common services that all primary care centers provide, where some primary care centers also choose to provide other more specialized services and sometimes even diagnostic services like laboratory and X-ray services. Also, the centers implement integrated programs in these primary care centers, and the integrated program, the main one is the expanded program on immunization, which we consider is an entry point to primary health care. Also, we have the essential medication program. We have the non-communicable diseases screening and treatment program, the malnutrition screening and treatment program, and also mental health is integrated in several primary care centers. To assure the quality of services, the Ministry of Public Health has embarked on a partnership with Accreditation Canada in 2008. And why Accreditation Canada? It was chosen because they are the leaders worldwide in primary healthcare accreditation. So Lebanon became the first country in the region to actually develop contextualized primary healthcare accreditation standards that currently govern the quality of service delivery and ensure that the quality of primary care services are sustained and unified among all centers within the network. At the level of financing, the Ministry of Public Health, under this contractual agreement that binds it with the private partners, provides the essential medications, both acute and chronic. We provide also the essential vaccines, which are on the national immunization calendar. We provide an electronic health system with different modules containing the electronic medical record. There are some mobile applications that can be used for service delivery outside the center for outreach activities and to report on the services that are delivered. With regards to the patient out-of-pocket contribution, as I said, the contractual agreement sets a ceiling for this contribution at 18,000 Lebanese liras, which before the economic crisis that we are currently witnessing was around $12. Currently, if the black market rate is around 17,500 Lebanese lira for $1, so the consultation is around $1. This consultation includes essential medication, and of course, vaccines are provided free of charge. Also, primary healthcare services are subsidized in some centers with the support of international NGOs from international donors, where even this small fee is waived. So people just pay like 3,000 Lebanese pounds for the consultation, including medications. We are currently also working on formalizing and standardizing the way that these INGOs and the donor funds are provided to primary care centers through a long-term primary healthcare subsidization protocol, where we are defining packages of care that should be provided to beneficiaries, including preventive and curative services, to ensure that there is a uniformity in the ways that services are delivered across this network. When we talk about the expanded program on immunization, as I said, since the expanded program on immunization is already integrated into primary healthcare, so everything that applies to primary healthcare also applies to the expanded program on immunization. But just to focus on the partnerships that we have under the EPI, we have both national partners and international partners. The international partners are generally the UN agencies, where WHO provide the technical support. UNICEF provide us with the support of procuring the essential vaccines. International NGOs, as I said, they provide subsidization of services. They also help us with in campaigns. Or for example, in the measles campaign, there was involvement of ICRC, for example, like an international NGO, MSF, and others. At the level of national partners, there is a collaboration with the national NGOs. As I said, all the primary care centers, or the majority of primary care centers, are owned by national NGOs. And also, since the expanded program on immunization is also being implemented by dispensaries that are outside the primary healthcare network, also these dispensaries are owned by national non-governmental organization. As for academia are involved in technical support for the program. They are members of the EPI technical committee. And also, as I said before, there are some primary care centers that are owned by academic institutions. The private sector is also part of the National EPI Technical Committee, where the Order of Physicians and the Lebanese Pediatric Society is represented. Also, the Order of Nurses is represented as a professional order. We have recently initiated a collaboration with the private sector. Although there was a decision by the Ministry of Public Health back in 2018 to provide the private physicians with all essential vaccines in their clinics, this decision was not very popular among the private physicians. And at the time, only like around 17 physicians enrolled with us in this program. But unfortunately, with the development of this economic crisis that we're going through currently in Lebanon, and with the continuous stockouts of vaccines in the private sector, the private physicians have resorted to the Ministry of Public Health, and this has reinitiated this collaboration under the expanded program on immunization, where the ministry provides the private pediatrician with the vaccines to their private clinics, provided that they administer them to children free of charge, just charging their own consultation. So for us, this is a window of opportunity to strengthen even more our collaboration with the private sector. Professional orders, I have mentioned that we are currently coordinating very closely with the Order of Physicians, the Lebanese Pediatric Society, the Society of Family Medicine, and general practitioners in Lebanon, since they are the specialties that are most involved in the delivery of immunization services in the country. As for outcomes and achievements, there are several outcomes and achievements at several levels. We have achievements at the level of controlling vaccine preventable diseases. Lebanon has been polio-free for 16 consecutive years. It's a country free from maternal and neonatal tetanus. The coverage with basic antigen is above 90%. We've been having an issue with measles containing vaccine. That's why we have initiated a national measles campaign in 2019, and it continued throughout 2020. The pharmacovigilance and effective management of adverse events following immunization. We have added new antigen to the national immunization calendar. PCV13 was added back in 2016, and Rota vaccine is currently under discussion, and we're hoping to introduce it very soon to our national calendar. We are also planning to expand the vaccination calendar beyond childhood to cover more age groups and vulnerable populations. We have a well-functioning and integrated vaccine preventable disease surveillance in primary healthcare and dispensaries, effective vaccine management with regards to cold chain, the provision of cold chain to primary care centers. Specifically now at this time, it's very critical since we are suffering a shortage in electricity. There is continuous electricity cutouts. So the cold chain is that was provided with the support of partners. The solar cold chain is helping a lot at this time. Waste management and continuous capacity building for the health human resources at the service delivery level. Of course, we're very proud with the human resources that we have, who are highly qualified and dedicated human resources. As for the challenges are many. One of the most important challenges at the system level, and as I said before, that primary care centers and other health outlets are politically affiliated. So it is very tricky to keep them all under the same umbrella, the umbrella of primary care, let them be visible as this entity that is affiliated with the Ministry of Health, the aim of which is to deliver high quality healthcare services to all beneficiaries residing on Lebanese territory in an equitable manner. Also at the system level, a concern is our heavy reliance on donor funding, which compromises the sustainability of services. Lack of human resources, as I said, although we have dedicated and highly qualified human resources, this economic crisis that we're going through has made us lose a lot of human resources to immigration. So sometimes we have high rates of turnover at primary care centers because human health resources are leaving the country. As I said, vaccine stockouts in the private sector, it can be considered a double-sided sword because although there are stockouts in the private sector, we are able to support and it has reinitiated and strengthened our collaboration with the private sector with regards to supplying vaccine to the sector. When it comes to access, of course, COVID has induced a lot of constraints on the mobility of people and their ability to reach to access healthcare services. It has estimated that COVID has caused a decrease around 30% in people seeking vaccination services. Also, there are geographic and security barriers to access. Some areas are very affected by the economic situation. So there are shortages of fuel. People cannot afford or cannot find the needed fuel to take their children for vaccination at primary care centers. There are also the financial barriers where we have the population that were used to receiving the immunization services in the private sector can no longer afford the cost of these vaccines. And sometimes they are not aware that essential vaccines are provided free of charge in the public sector. Limited awareness, we can also refer to the fact that immunization is going back in priority on the priority list of parents due to other emerging concerns. As I've mentioned before several times, the severe economic crisis that we are currently facing is one of these challenges. At the service delivery level, I have touched upon the fact that we're losing human resources. So the providers are, the number of qualified providers are decreasing. Staff are less motivated, and there is also, on the other hand, an increased demand for services because they are more affordable, and so people seek these services. So it is just like a vicious cycle. Human health resources are leaving. The people who are left working at primary care centers are overburdened and overstretched. As for promising interventions, we have several promising interventions. I've talked about the collaboration with the private sector, with the private physicians. So we think that now it's a very timely collaboration to be building on, to be strengthening. So when the situation improves, we will be having this already structured collaboration with the private sector, which I might tell you, and you might know that in Lebanon, the private sector is very robust and very powerful. Initiation of routine immunization strengthening activities, now that people are more flexible in their mobility after the immunization rate with COVID vaccine are increasing. So we will be looking at strengthening immunization activities with our partners, the WHO and UNICEF, focusing on community engagement, on media campaigns, and on outreach activities, of course, through primary healthcare centers. We are looking forward to unifying the vaccination calendar, because although our national calendar contains the essential vaccines, there are several optional vaccines that are available in the private sector. And the calendar is not always unified between the public and the private sector. So currently we are working with the EPI Technical Committee on the vaccination calendar unification. Expansion of the EPI calendar is one of the aims of the programs, and we are trying now to expand by adding new antigens to the calendar and covering more vulnerable age groups. Initiation, the collaboration with private schools, where we have already initiated this very successful collaboration with the public schools. Now we are moving to the private sector, to the in the educational private sector. When we are looking to link every school, be it public or private, to a primary care center to ensure that all children are fully immunized up till their age before enrollment in school. And also we are working a lot on enhancing our electronic applications, the MERA application, which is the mobile EPI registration application. And we are working on developing a caregivers application that will remind parents of the appointments for vaccinating their children. Mind you, we have also achieved changing the reporting system in the EPI from paper-based reporting to completely paperless reporting. So this is also one of the achievements under the EPI. And to expand the program on immunization, the accreditation beyond primary healthcare to ensure the quality of services that are provided, be it within primary care centers or outside primary care centers as outreach immunization activities or activities in the dispensaries. I guess this is all from my side. I will be available for any questions or any clarifications that might arise. Thank you.
Thank you so much, Rima, for this very comprehensive and very informative presentation indeed. I learned a lot about the primary healthcare services in Lebanon and the role of the private sector in delivering or really in all levels of the primary healthcare system, from the top down to the delivery of the services. And I'm sure a lot of a question, I personally have a lot of a question that I'm going to raise later on after completing with the third presenter. And the third presentation, dear colleagues, will be from Afghanistan, and Dr. Sardar Parviz. He is going to present to us the public-private partnerships in Afghanistan on behalf of Dr. Nazari, who is, as I mentioned, unfortunately was not able to attend. He is outside Kabul, and there are some logistic issues. He cannot not prevent him to attend today. Dr. Parviz, the floor is yours now, please. You have 20 minutes as your colleagues to present, and then we will start with the questions and answer after that. So please go ahead, Dr. Parviz.
Thank you very much, Dr. Lame, for the nice introduction. And let me share my screen.
Sure.
I don't know why the full screen. As we all know that the public-private partnership is the backbone of the health system in the most of the countries in the world, and Afghanistan is one of them, and the public-private partnership played an important role in the progress of health indicators in Afghanistan. Therefore, in today's presentation, we will talk about the background health system in Afghanistan, and also the health reform inclusion of or engagement of the private sector in the health sector, achievements and challenges. And also at the end, we will discuss about an assessment that recently GHD conducted in Afghanistan on the public-private engagement, and we will discuss the findings and recommendation of that study. This is the map of Afghanistan. As you can see that Afghanistan is a landlocked country. It has a long border with Pakistan, a very narrow border with China. And the country experienced different model of health systems. For example, before 1990, the health system was totally provided through the government for free. But after 2002, the health system was reformed, and the basic package of health service was developed with the partnership of other partners. And under this strategy, there was a unique or certain type of health facilities: basic health center, comprehensive health center, district hospital, provincial hospital, regional hospital, and tertiary hospital. And later on, they revised it and they added the health sub-centers and mobile health team in order to increase the access to the health system. And also at the bottom, if we can see, there is the health post. In the health post, one male and one female community health workers working, and the main responsibility of community health worker is to refer the patients from the community to the nearest health facility. And of course, they are providing very basic health services as well. After that, in 2006, the Gavi provided support by the name of CISO Type B. And this support was for the Pakistan and the Democratic Republic of Congo and Ethiopia. And this support was provided to Afghanistan in 2008. With this support, the partnership with the private health service providers was established in four provinces, in a very remote and insecure area of these four provinces. And this project was provided the immunization services and the basic reproductive health services. This project was a pilot project, and it was implemented for 5 years. In 2013, it was evaluated by a third party, and the result shows a tremendous progress in the health indicators in these four provinces. So it was expanded to 6 provinces. And the health system in Afghanistan is almost totally dependent on the donor. The government contribution is 6%, but still the huge burden of this health expenditure is on the shoulder of the public. Almost 75% of the health expenditure is out-of-pocket expenditure, and 21% of the health expenditure is contributed by the donors. The main donor is USAID, World Bank, EC, with these backgrounds. And also this basic package of health services contracted out through a bidding process to the NGOs. And there are two modalities for the contracting out. The 31 provinces were contracted out to NGOs, and 3 provinces was contracted in under the strengthening mechanism with the Ministry of Public Health. It means the Ministry of Public Health was implementer in these 3 provinces, and it was a pilot project. And after a period of time, the Ministry of Public Health was planned to evaluate it, and they will decide whether they should go with the contract out or contract in. But unfortunately, during the last 20 years, still these projects are going on in parallel, but the Ministry of Public Health couldn't make a decision whether should go with the contract out or contract in. This slide shows the accessibility of the health service in the different provinces. However, this map will be what changed during the last 1.5 months because the government has changed. The green color shows the accessible areas, and the yellow color shows the hard to reach areas, and it is mostly due to the inaccessible geographical barrier, and the red one shows the difficult to access. It is mainly due to insecurity, but now I believe this problem is solved because the government has changed, and this insecurity area now is accessible. And also, if we look at to the provision of EPI services, Afghanistan has a national cold chain center at the national level, and they have 7 regional cold chain system, and they are receiving their cold chain and vaccines from the national level. And in each province, we have a small cold chain centers, and they are receiving their vaccines from the regional, and the health facilities are receiving their vaccines from the provincial cold chain centers. And the private health sectors are receiving their vaccine from their nearest health facilities. They are not linked with the provincial cold chain, which is an issue for the private sectors. And also the data flow of the API from all fixed centers, outreach, and mobile. The data comes to hard copy to the provincial level. At the provincial level, it is entered to the computer, and the replica is sent to the national level. And at the national level, these replica from all provinces are synchronized, and it is synchronized with the national HMIS database. And the reports goes or disseminated to the partners from the unique systems. If we look at this data flow, the parts of the private sector or the contribution of the private sector is missed because they are providing the reports to the health facilities, and the health facilities combine their reports with themselves and send it to the provincial. If we want to know the contribution of the private sectors, we don't have such a reports at the national level. And the immunization, governance, and coordination at the national level, the highest forum for the coordination for the governance of the EPI is the ICC, which is chaired by the minister or the deputy minister, and NITAC as a technical or oversight independent forum. And HSS steering committee mostly manage the funds for the EPI, and the EPI task force, which is mostly deal with the technical issues. And at the provincial level, we have the Provincial Public Health Coordination Committee. For the planning and accountability, at the national level, there is the CMYP or Comprehensive Multi-Year Plan, and at the provincial and health facility level, they have the micro planning. With the implementation of these methods, the health system has some achievements and also some challenges that we will highlight those achievements. Since 2002, substantial efforts has been made in the health system in Afghanistan, and it results tremendous achievements for the health indicators in terms of access, in terms of coverage, in terms of quality of the health services. For example, the coverage was increased from 9 to 10% to 87% within the 2 hours walking distance. The coverage also to 85%, and particularly the outcome indicators were increased. For example, the maternal mortality ratio or under 5 or infant mortality rate. And before 2002, Afghanistan had the highest maternal mortality ratio. It was 1,600 per 100,000 live births. And it is significantly decreased with the implementation of the basic package of health services. Also regarding the coverage of the API, actually this is not the administrative data, it is based on the survey data in different years. If we look at, it shows a progress in terms of the coverage, but still there is a difference, or there is the coverage in urban and rural area shows an inequity. Another main challenge is of the health service in Afghanistan is the maldistribution of the health facilities in the country. Just as an example, I brought one provinces, which is called Helmand, and it is the largest province in Afghanistan. If we look at today, distribution of the health facilities, almost all of the health facilities in the quarter of this province. The remaining, there is no health facilities, or even in one district there is one health facilities, which shows unfair or unjust distribution of the health facilities, and these people has access problem for the primary health care. But another province, if we compare this, the distribution is very well. Considering all these issues, the distribution of health facilities, and we all know that in this situation, the private health sector plays an important role. Recently, GHD conducted a rapid assessment of the public-private partnership in Afghanistan in one province of Afghanistan called Paktia. And now we will very briefly touch upon some findings of this study. But if you are interested to have the complete reports of it, it is available in the e-library of the GHD website. You can find it from there. The methodology of this study, the discussion to conduct this study was started at the beginning of 2020. We developed the questionnaires and protocols, and then it was translated to the local language. And of course, we got the IRB approval, which was a bit time consuming. And this data collection was started in December 2020, and the analysis and report was developed in January 2021. And we had a dissemination workshop in June 2020, and the results and findings was appreciated by all in-country partners. And in this study, we used the open-ended questions, qualitative data for the in-depth interview with the key informants, and also we used the standard questionnaires for the health service providers of the private health service providers, and also we had some exit interview with the healthcare seekers, and also focus group discussions. According to the findings of this study, when the surveyors assessed the knowledge of the vaccinators among the private health service providers, when they asked about the time of administration of the BCG, only 65% respond the correct answer that the BCG can be administered from for the newborn up to 1 year. And also when the data collectors asked about the time of Penta-3, only 75% of them mentioned that it will be in 6 weeks, 10 weeks, and 14 weeks. But very strangely, 90% of the respondents provide the correct response about the hepatitis birth dose, which is within 24 hours after the birth. However, the hepatitis birth dose is not introduced in all health facilities. Only hepatitis birth dose is introduced in those health facilities that they have the delivery room. And also about the protocol assessments, only 65% of them provide enough information about the benefit of the vaccine, about the side effects of the vaccine, about the date of next visit or second dose of the vaccines. And 94% of the vaccinators properly or correctly administer the BCG in the left upper upper arm, and also with the correct angles. Regarding the satisfactions of the healthcare seekers from the private health service providers, they had the exit interview. And the yellow and green color shows the satisfaction of the healthcare seekers, and the red and blue shows the disagreement or dissatisfaction of the healthcare seekers. If we look at that to this at the bottom, the last one, look at still the access is a challenge. When they asked about the distance between the health facilities, they were not satisfied, and also about the cleanness of the health facilities. And also when we interviewed 20 patients, they were unable to explain their problems and second visits. Either they were not received this explanation, or they received the explanation, but they couldn't understand, or the information was not provided in a proper way to them. The recommendations are actually all the recommendations provided based on the findings of this study. The health service providers need to appropriate and quality trainings, and also they need appropriate and regular supervisions through the provincial and national health authority. And also the establishment of the private health service providers need to be more discussed, or engagement of the community elders in order to increase the access. And also we need to develop a transition plan for these public health service providers, because for the sustainability of the programs, sometimes the fund will stop, and these services should not be collapsed. These were the recommendations about the study. That's all. And this is the picture of Nuristan, the very underserved province of Afghanistan, in which the public-private partnership is active in this province, and it played an important role in this province. Thank you.
Thank you so much. Thank you, Dr. Parviz, for this great presentation. And Dr. Parviz He is currently working in GHD Infinite as polio and immunization specialist, and he was the former API director for Afghanistan for a long time, and also engaged in a lot of frontline, managerial, as well as executive level experience, and working with different organizations, including WHO, other ministries, and European Union, CDC, and others. So thank you so much, Dr. Parviz, and our thanks are also extended to our colleague, Dr. Nazari. So please extend our best wishes for Nazari, and have hoping we will see him soon, inshallah. In fact, we have a lot of questions and had been raised by colleagues, and just to start with Dr. Jane, I think probably this is a complicated question somewhat, but very, very quickly probably you can address, Dr. Jane, regarding the polio eradication. It was mentioned that it is a very successful example of public-private partnerships with a lot of partners have been engaged. Yet, the process of polio eradication had been delayed a lot. So what are the main causes from your perspective? What do you think?
Yes, there has been a lot of delays. I think that a lot of the delays has to do with a lot of the, sort of the insecurity issues and security challenges that we face. One example that's one example. Another thing is just recalibrating what tools, public health tools we would use to eradicate polio. We had to refine, like for example, in Africa, we were trying to locate nomadic populations and reaching every child that was 0 dose. And so we had to follow the patterns of animals. And some of those things we had to change our strategy to reach everyone. It has been a challenge. I think it is a criticism for the partnership, but I think the partnership does take it to heart. They hear the comments, and then the partnership sort of recalibrates and come up with new approaches to get us to 0. But it's not just the leadership, the GPI at the global level, but it's also the commitment at the regional and the country level. Over.
Thank you so much. A question really for Dr. Parviz from Afghanistan. Really, it is not a political question, but as you mentioned that one of the issues in primary healthcare in Afghanistan is the donor dependency, and the good amount of fund come from external agencies. What do you feel about after this political changes that occur in Afghanistan? What is your view about the coming time regarding this issue?
Actually, to be honest, in the current situations, the government of Afghanistan needs more support from the donor community than ever, because almost the health system, once again, it goes to the collapse. Therefore, they are in need of the donor aids, but the negotiation is going on, and hopefully the supports will be provided. But it is very difficult to say that how would be the situation after a period of time. But at least the negotiation is going on, and we hope everything will be all right.
Thank you so much. A similar question somewhat to Dr. Rima, and really in spite of the difficult situation that Lebanon is facing currently, and but I can see that there is a tremendous achievement still are continuing and going on. How can you explain that? in spite of the limited public support and over-dependence probably in some areas on the private sector to provide, but still I think from the, for example, for the coverage of the vaccines and including new vaccines and a lot of issues that make the vaccination program in Lebanon is something, an example really for in the region. How can you explain that?
Well, I think the crisis is not yet old enough to have this extremely negative impact on the program. We're still reaping the results of continuous work on the expanded program of immunization since 1987. And there's no doubt that the collaboration with the public-private partnership and with the private sector has a lot to do with increasing the coverage with vaccines under the expanded program on immunization. Regarding your question, of course, donor funding has increased to Lebanon after the unfortunate Beirut port explosion last year. And the Ministry of Public Health has tried to channel those funds in a way to strengthen the already existing network of the primary care centers in order to provide people with the essential services. And the way that we are working and collaborating with different partners, the way that we are channeling donor funds and trying to make them available where most needed, I think this is what's keeping us afloat for now. Over.
Thank you, thank you. And I think probably the governance and the monitoring by the public and the media, do you think that they are playing a role also? You have a strong private sector indeed, and a strong media, and yeah, some pressure from the public as well.
Yes, it does, of course, play a role. Also, there was one of the questions in the chat on how does the government monitor the quality of services that are provided by the primary care centers. So we have a field team of coordinators who are dedicated to actually visiting primary care centers, providing on-job coaching, technical support, monitoring activities, ensuring that the centers are providing proper reporting to the central level, and following up with the center by center. So we have a primary healthcare coordinator in every governorate. They conduct monthly field visits to these centers and support them technically, as I said. Should I answer the questions that were in the chat, or you prefer to leave them for later?
Let us distribute the question between the presenters. And a question for Dr. Jane. One of the colleagues had asked about the possibility of duplication and overlapping in the support that private sector can give. How can you address this issue?
I mean, I think with the overlap that you mentioned, I think it's really critical is with whatever partner that comes to the table, that you identify clear roles and responsibility. So there's no duplicate actions, efforts of those partners. So for example, as I mentioned, you know, with CDC, we do the monitoring evaluation, and we provide the technical assistance with WHO and UNICEF, whereas, you know, Rotary National would be responsible for doing the advocacy work and raising funds for GPI. So everyone has a clear role and it's linked to their expertise. Over.
Yeah, thank you. Another question that had been raised by another colleague really about the duration needed to build a successful global partnership, for example, like the one for the polio and the other one for measles. That if we think of COVID, for example, how much time we need in order to achieve such a successful partnership?
That's a difficult question.
Yes, indeed.
I mean, I think it's really evolving. It'll also depend on the political commitment and the will of the country, regional, global levels. We do need it at every level for it to be successful. It will take time, it will vary. I mean, every country and region has their own sort of issues or situations that you have to address. And I mean, I think it's a growing process. I mean, GPI has been in business for over 30 years. We have grown a lot. MNRI has been in for almost 20 years. And so we did have our growing pains, but we are learning from the mistakes we've made to make our partnership stronger. And I can see that with COVID, you know, with the stand up of COVAX and others, like what are those growing pains or Act A that we will sort of experience and try to learn from these other initiatives to make us stronger. Over.
Yeah, thank you. But I think still we have a good proportion of inequities, and for example, in the provision of vaccines between different countries, that a lesson that we have to take very seriously. Otherwise, we will keep probably have a vicious circle. Yeah, a question for Dr. Perwiz from one of the colleagues, that in spite of the reduction of immunization during 2020 and 2021, yet the number of polio cases in Afghanistan during this period have been reduced. What is the explanation behind that?
I think the number of polio cases, there might be some reporting issue, because for sometimes the surveillance was collapsed due to the COVID-19. But at the same time, the negotiation was going on with the on that time, anti-governmental agents, and some area which was banned for the polio campaigns, and it was once again released recently. So most probably it was because of that. But to me, it looks surveillance issues.
Do you expect probably we are going to see some consequences of this low immunization coverage during this time, the coming time, for example, that's we are going to have a rebound increase? What do you think?
No, actually, to be honest, after that, we will not have those problems that we had in the past. For example, in the most endemic and high-risk areas, the polio campaign was banned. And now the government has changed, and those areas is not, we will not have any problems with the implementation of the campaign on those areas. And even I expect that the polio circulation will be stopped within 1 or 2 years, because if we look at the cases of the polio, it was only in the south and east parts, and in the insecure areas. And there was 2 main reasons for the polio cases. The first one, insecurity, and the second one was the open border with Pakistan. And now, at least, the insecurity is solved at all, and there is no issue anymore, and we can conduct the campaign. And even in this month, the Orozgan, one of the insecure provinces that we and the Ministry of Public Health couldn't supervise during the last 4 or 5 years. But in the month of October, the GHD team has planned to go to the Orozgan province, because there is no issues anymore there. And the campaigns the same if the international support was there, and the campaign will be implemented in a good quality, and we will have access to all children, and hopefully the circulation will be stopped within 1 or 2 years.
Great news indeed, thank you. Dr. Riba, really, a few weeks ago, I raised a question in a forum for the Arab Public Health Association, and I just highlight how can the Arab Public Health Association and other regional Association can give a hand to Lebanon in the area of primary healthcare, public health in general, and primary healthcare services in general. If I ask you to pinpoint 3 areas that regional agencies can give a hand to public health in general and the PHC, primary healthcare services in Lebanon, what do you think? You are muted, Dr. Rima.
Yes.
Thank you.
Well, it's a bit tricky question with no time to think, but I think that currently we're struggling mostly with the deterioration and the immunization rates. So we would need support in promoting, attracting new beneficiaries to the system in order for us to try to raise the immunization rate to the pre-COVID and pre-crisis situation. Also at the level of the quality of services, although the accreditation collaboration was totally funded by the Lebanese government, it has, the funds have run short, and it's compromised our collaboration with Accreditation Canada and the ability to conduct accreditation activities. So there is, it might be a potential area of support and reinitiating and supporting again the implementation of the primary healthcare accreditation program at the primary care centers. So these are the main 2 points that come to mind for now. Over.
Thank you so much, Dr. Rima. And indeed, our time is almost over. So if you allow me, dear colleagues and the friends, to express my sincere thanks and appreciation for our presenters today, Dr. Gina Hill from US CDC, Dr. Rima from Lebanon, and Dr. Serdar on behalf of Dr. Nazari from Afghanistan. Thank you so much for your time and the presentations. Very useful, very thoughtful, and a lot of insight that I hope our colleagues in other countries in the region will get use of the example that had been mentioned and the discussion that we have. And my apologies for the colleagues who put their question, but unfortunately we were unable to address them. But I can assure you that we are going to address them written after asking the presenters for their responses, and we are going to disseminate all the responses, including all the discussion that had been made, and now in all the attendees using their emails. Once again, thank you so much, and wish you a great day. Thank you.
Thank you very much for the nice facilitation.
Thank you. Bye-bye.
Bye.